This podcast represents the opinions of our hosts and their guests only. The content here should not be taken as medical advice and is for informational purposes only. And because each person is so unique, please consult your healthcare professional for any medical questions. Welcome to Once Shattered, Picking Up the Pieces, a podcast devoted to changing the way eating disorders and mental illness are viewed in our society. With your hosts, Jack and Linda Major and Ellen Bennett. Today's guest is Dr. Jennifer L. Gaudiani. Dr. Gaudiani is the founder and medical director of the Gaudiani Clinic. Board certified in internal medicine, she completed her undergraduate degree at Harvard Medical School at Boston University School of Medicine, and her internal medicine residency and chief residency at Yale. Dr. Gaudiani has lectured nationally and internationally, is widely published in scientific literature, as well as on blogs, and is a fellow of the Academy for Eating Disorders, and is a former member of the editorial board of the International Journal of Eating Disorders and the Academy for Eating Disorders Medical Care Standards Committee. You can find Dr. Gaudiani's entire bio in the show notes.
Welcome, listeners. We're so glad that you are here with us today. This podcast is brought to you by our nonprofit organizations, the Emily Connection and KMB for Answers. I'd like to welcome my soulmate and best friend, Jack Major, and our dear, dear friend and fellow advocate, Miss Ellen Bennett.
Well, welcome, listeners, and thank you for being with us again today. We are so excited with our guest today, Dr. Gaudiani. We're looking forward to this interview for a long time. And please remember the links for Dr. Gaudiani are in your show notes, and also the links for us at the Emily Connection and KMB for Answers.
Dr. Gaudiani, welcome. We're thrilled to have you here. And as I was driving over today, I realized, oh my goodness, I've known you for 12 years. And over the course of that time, I've been fortunate enough to see you every few years or so. And that has been such a gift. So welcome, and we're thrilled to have you here today.
Oh, thank you so much. I find myself with just tears in my eyes at the prospect of seeing you, beautiful, dear people whom I've just shared such important experiences with over the years.
Oh, yes. And we have a very personal connection with Dr. Gaudiani as well. And we're so honored to welcome you here today. And for our audience to know, she is globally recognized as a leading physician in the field of eating disorders. Additionally, and on a personal note, I can say that Dr. Gaudiani is one of the most compassionate individuals I've ever met. So welcome. And I just like to kind of set the tone with a quote. The things you do for yourself are gone when you are gone, but the things you do for others remain as your legacy. And that is by Kalu Nuduki Kalu. I have no idea if my pronunciation was right, but I love the quote.
Yeah.
How do you guys, that resonate with you?
Yeah.
Yeah.
Yeah. I mean, just certainly what we're all doing is for others. And
certainly our guests too, first and foremost.
Yeah, I think along this journey, we've all experienced that it's the actions and the words that are so meaningful.
Yeah.
So without further ado, I'm going to start with the first question. So Dr. Gaudiani, can you share how you first became interested in medicine and what drew you to specialize in the field of helping those with eating disorders?
I would love to. I have known since about age 6 that I wanted to be a doctor. My dad's a cardiac surgeon, and I grew up in a time before HIPAA, for better, for worse, and really got to spend much of my childhood with him in the hospital, rounding on patients in the intensive care unit and shaking hands at bedsides post-operatively and seeing patients with him in his office. And then when I was 13, I finally got privileges to stand next to the anesthesiologist and watch surgeries. So I really had this incredibly unique opportunity to learned some of what I might call the body language of medicine. Although I didn't know the actual terms, I feel like I had this opportunity, sort of like a native speaker, to learn it from when I was little. And he is a wonderful physician who's still operating at the age of 78, and gave me such beautiful models for what it was to sit with patients' uncertainty, with complexity, to be responsive to their questions and answer them at a level that deeply resonated with them and that showed a lot of humility and also a lot of warmth and grace. So that was such a beautiful role model, and I have a long history of physicians in our family. My two Italian great-grandfathers were physicians. One graduated from Columbia Medical School in the early 1900s at the top of his class and was, quote-unquote, relegated to family practice because the dean of the school told him, no Italian is ever going to become a surgeon under my watch, which is very interesting. And my other great-grandfather came over from Rome already as a trained surgeon, and they were best friends. So, I have this wonderful, rich tradition, and I always knew I was going to be an English major, and I always knew I was going to be a physician. So the things that brought me into the field of eating disorders include, I think, a melange of things. My sister has always been very gracious in letting me share that she is my original muse. She had an eating disorder for many years and is recovered. I additionally am a feminist, and I believe deeply in supporting women and of course, supporting everybody in the decisions that they make in their bodies, and meeting them without judgment, but with love and warmth and a particular focus on their strengths rather than the ways in which they suffer, to create relationship and to find a pathway forward. And in the final analysis, it was luck, as so many of the best things in our lives are. When my husband and I moved to Denver in 2007 and I started work at the inner city teaching hospital for the University of Colorado because I speak Spanish and had always taken care of inner city patients, I learned that there was the top medical stabilization unit in the country, acute, located at Denver Health. And I answered an inquiry as to who might be interested in helping to grow and run that program. So no matter how careful we are thinking that we control our pathway, so very often it's about caring for ourselves and others in ways that when remarkable opportunities offer themselves up, we have our eyes and our hearts open to say yes to them.
Oh my gosh.
Beautifully said.
Can we clone you? Just, so you're everywhere. How long did your dad work as a doctor?
He is still operating now. So, Gosh, he must have graduated from med school in the early 70s and continues to practice to this day.
I just saw something on LinkedIn. That's what I do now that I'm retired. I just go on, all these things. But there was a doctor on there talking about the current environment and how he sees that current physicians now may only work 5 to 10 years before they move on to something else. And that's sad that, you mentioned HIPAA and all the things. If we can only go back a little bit in time and have doctors practice the way doctors are supposed to.
Yeah, there's such complexity
tied
around that.
Yeah.
For sure.
So.
It does. It seems like their hands are tied a lot of times
Yeah.
because of HIPAA. Absolutely.
So.
My dad and I often talk about how we might be the two happiest physicians in the United States. We've just been so fortunate to control a lot of the elements that many physicians don't get to control. Yeah. But both he and I feel a sense of enormous joy as we wake up each morning and we go, oh, I get to do this again today.
That's wonderful. Wonderful. So you mentioned acute, and you were the medical director at acute, and you oversaw the unit and worked with patients that were severely impacted by eating disorders. and other medical issues. Without the kind of care that was offered there, so many probably would not have survived. I'm sure your team saved so many lives. So what do you take away from your time there? And was it hard to believe, hard to leave? And was acute the only place in the country for people to go when they were that severely compromised?
Yeah, I think acute was and really remains the top medical stabilization program for critically ill adults with eating disorders. And gosh, I learned so much. First of all, I learned an entire subspecialty at acute because I came from a knowledge base of zero. Lots of heart, but no knowledge base. And I left after 8 years knowing so much more. And yes, knowing about the medicine. I mean, the medicine is wonderfully interesting and delightful to practice. But much more than that, I learned about the humans. I learned about their story. One of the benefits of having been an English major who focused on close reading of poetry. I mean, the science classes were so hard for me. But one of the benefits there was that I was instantly interested in the entire spectrum of their story. What was it like in their lives? What was it like living with this illness? How had they interacted with the medical world, with the treatment world? And what impact had it had on them? And so it was the delicious, beautiful humanity of the extraordinary humans that I had the opportunity to treat that really, really filled my soul. And then I wanted to learn the medicine better so that I could best care for them and support them. But I think the impact was less about getting the right dose of spironolactone for, withdrawal edema management, and more about them feeling just the beaming warmth of my high regard for them. And so many of my patients at that program had just been through so many rounds of feeling like disappointments, which was excruciating because I don't know that there's a population of individuals more sensitive to the sense of being a disappointment than these wonderful folks, because either they were disappointing their loved ones, their values, and their wise mind by engaging in the ED, or they were disappointing the ED by engaging in recovery. And so understanding, learning from them that at all times they were feeling like a radical disappointment, and the exhaustion that came with that felt so important. It's not the ED behaviors per se that are complex. It's the ways in which the constant conflict within oneself exhausts the soul, even as the body is exhausted as well. So what I ultimately learned most from acute was the spectacular humanity of the individuals and the ways in which their heart, mind, soul, and body were all tied so closely together, and that one had to address all of those elements to help them even with their medical stabilization. And that's probably what I took the most from acute as I headed into my private practice outpatient. And yes, I did miss it, of course, but I was also so excited to try to start earlier with patients before they got to this place of critical medical illness, very narrowly defined by the admission criteria for that program, and instead say, oh my goodness, if I can interact with patients earlier in their timeline, earlier in their disease process, earlier in their medical challenges, and I can see a much more diverse group of individuals as far as age, diagnosis, body shape, and size, then maybe I can forestall some of this. Maybe I can help people remain in their lives wherein their other healthy identities live, their professional, academic, athletic, interpersonal identities are much more richly engaged in the outpatient world. so that I can try to forestall some of those other outcomes. And that was that, and a desire to know my patients over time and not just love them for the 2 weeks they were admitted to the hospital and then say farewell, but to really have the full spectrum of, Dr. G, I'm graduating. Dr. G, I got engaged. Dr. G, I'm pregnant. Dr. G, I've buried my mother. Like these really important life milestones I wanted to be at their sides for.
Yeah, I know when you met Emily there, how you connected with her as a doctor of pharmacy, and just learned about her, about Emily. What was the true Emily before the illness, took over her life. So I thank you for that.
Well, the illness had already taken over her life. That was her.
No, but I'm saying that she.
Oh, but she connected with her true self.
The inside.
Yes,
Emily.
yes. It was magical to watch because, we both come from Italian roots. Yours are surgeons, mine are barbers.
But they were doctors a long time ago.
But my wife's father, my grandfather always used to say forte e gentile. And my father was always one with sayings, and that's one that came from his father. And I always thought it meant strong but gentle, but it means strong but kind. And that's what you exude, that strength within yourself, and yet the kindness and compassion in someone else that makes them feel safe. Yeah. And yet, sometimes you have to be blunt, and somehow you meld it together like no one else I've ever seen. So it was beautiful, and I thank you for that. Were you gonna say more of a question there, or did I just jump in when I shouldn't have?
No.
Okay, you're
fine.
good. Sorry.
No.
It's my turn. Dr. Gaudiani, you are an inspiration. And I love hearing about your early experience with your dad, because it really kind of pulled together all of that, and how working with people and helping them heal is innate to who you are. And it helped me, like Linda and Jack, you were the only doctor that connected with Katie. But it was, and I'm going to call it magic because I can't, there's a sprinkle of something incredibly unique that you have, but you own it and you understand that and you use that to help other people. And it is just incredible. So thank you for sharing that about you, because I think it is something a lot of people really need to think of, because that ability to connect with compassion and look at the whole individual, I think more and more we're realizing that that's essential. And it needs to be the standard, especially with the eating disorder community and mental health, that they're more than their eating disorder. They're more than, they have lived this incredible, full, rich life that they need to reconnect with, and how important that is. So anyways, my original question was supposed to be kind of expand on how and why you opened the Gaudiani Clinic. But what I'd like to do is give you the opportunity to tell us about how the Gaudiani Clinic has kind of evolved over the past 7 years and shifted, because I'm sure you started with a concept in mind, and today you're like, aha, this is where we are.
That is such a great question. Oh, I've learned so much. I came out of acute thinking I knew some things, and I did, but I had an entire other set of skills to learn, medically, interpersonally, intrapersonally. So, these last 8 years have marked the greatest professional and perhaps personal growth of my entire life. And I'm 48 now, so it's wonderful to experience that growth. Medically, I thought that I was going to be treating somewhat milder versions of the same diagnoses that I treated at acute. And that probably makes up 10% of what I actually do, which has been so fascinating. Yeah. I think that having only witnessed this very so-called highest level of care, I had the thought that outpatient was just a sort of a milder version of that. Oh my heavens, I could not have been wrong. I have the most incredible high regard for the outpatient therapists, dietitians, and other providers who care for these patients, because outpatient is the wild, wild west. At acute, I controlled everything. In my clinic, I get to see patients between once a week and once every couple of months, and they are doing it on their own otherwise. I mean, it's extraordinary. So first of all, just the experience of helping these incredible patients understand what's happening in their bodies, undo some of the gaslighting they've experienced when physicians, well-meaning, just who didn't know the details, told them the wrong thing or told them that it was all in their head. And then start to work towards a place where the body functions better. Recognize that brings its own complexities, because the second the body feels better, the eating disorder goes, oh shoot, I'm not sick enough. Even if the idea is to remove some of the physical barriers to recovery so that their journeys become smoother, the truth is that there are complexities to helping people feel better. Some feel, gosh, I haven't felt this good since 4 years ago, but I'm doing the same behaviors. What does that mean? Am I supposed to go harder now? I mean, it's really tangly. And so I've had to recognize all of these complexities and care for myself, which I thankfully do in many ways, not the least of which is brilliant supervision within my clinic, where we have so many experienced clinicians. In order to understand, what am I bringing to this? What am I hearing from my patient? And how can I respond in a way that is the most loving, the most supportive, the most helpful to what they're going through? So, this complexity, I don't think anybody could have told me about it. I think that I just had to live it and learn through it and develop a whole new set of stories, conversations, and techniques in order to help my patients over those treacherous waters. So that's been really, really interesting. My knowledge base purely about the wide array of medical complications that don't necessarily happen due to an eating disorder, but that end up in a terrible negative spiral where the patient has an eating disorder and OCD and PTSD and ADHD and mast cell activation syndrome and POTS and all of these other things. And when one goes down, the others are all pulled down with it. So then it's a matter of learning how to reverse the spiral and start helping them lift back up again. But what threads do you pull on when it seems like you've just got a hopelessly tangled necklace? Where do you start gently teasing out one chain so that it loosens and you start to see order in it again? And a lot of it is just sitting with the patient, as I say, in the shit, and being like, okay, let's, what's your top priority? What's the thing that's really, really preventing you from making progress right now? It couldn't be further from algorithmic medicine, because each person is so unique. And they might say, Dr. G, it's the bloating. If my bloating were a little bit better, I would have fewer body image issues and I would feel less fearful of eating, and I might be able to make progress. And then when I nourish myself better, my energy might come up. And when my energy comes up, I might feel more able to engage in the things that give me identity outside my eating disorder. And when that happens, I might be able to stop purging. It's like this fascinating web, and each one is different.
Yeah, we're just sitting here going, wow.
Absolutely.
So, I see a lot of people out there, and there's one in particular who's in England. His name is James Downs. And, James. And there's so many places now that say that patients are treatment resistant, right? And they're failing treatment. But nobody talks about, the treatment center failures because they don't. Yeah, thank you. And I don't want to throw them under the bus. They're needed out there, but they just can't treat everybody, like you said, the same. And they have to delve into so many of the underlying issues besides just the...
Right. Yeah. Absolutely. It seems that since COVID, people are much more aware of all mental health issues, and eating disorders are finally part of the conversation. There's been some progress made, but we have such a long way to go as far as affordable treatment, insurance coverage, and comprehensive care, and the lack of support for people when they have to assimilate back into society after treatment. What are your thoughts? That's a loaded question, I know.
There's a lot there. With regards to the precipitous step down after treatment, even if, and we know it's not necessarily the standard anymore, even if someone both tolerates and has payer sources to go through inpatient, residential, PHP, IOP, the step down is still precipitous back into one's home life. The stressors, the daily reminders of where behaviors occurred or where a fight occurred that made one's soul drop and made the eating disorder more appealing. I really like, and everything takes resources, which is very complex. I really love eating disorder coaches. They've become a wonderful addition to the field in the last few years. A great bridge for a lot of different types of step down or step up. So that's been very helpful. The notion of being able to have access to care, and access incorporates a lot. So I want to sort of pause on the concept of access. Access doesn't just mean good enough insurance and enough personal resources to pay the copays. It also means geographic access. If your insurance only covers a program in your state and the one program is 5 hours away or there's none, that's a big problem. Access also means, do you look like, quote unquote, both in terms of your actual look, because we know that size stigma remains a tremendous problem in the field of medicine and in eating disorders, but also look like in terms of your other diagnoses, the kind of patient that a program will accept. It's so interesting that many people who are experts at higher levels of care still see, even through the diversity of patients they care for, only a subset of the individuals, because they just decline admission to those whom they feel are too behaviorally complex, too medically complex, too quote unquote somatic, too troublesome. We have a history recently of getting a referral from a higher level of care, and the sign out that my partner got from the staff there was pretty negative. This patient is really difficult. She's been making symptoms up, and her behaviors have really disturbed the milieu. She won't eat, and she insists on tube feedings when we know she doesn't need them. She's really problematic. And that's the kind of patient that my partner saw and was like, tell me everything. And it turned out that she had at least one, if not two, diagnoses that had never been made before. And when she started being properly treated for those, her symptoms improved. And they were not imagined, and they were not behavioral, and they were not trying to disturb a milieu. She just wasn't getting the treatment she needed. And in that context, as she stops being someone's problem child and becomes a beloved, wonderful, success story, that changes the energy completely. So that's also part of access. If you have such severe digestive complexity due to Ehlers-Danlos syndrome or mast cell activation syndrome or pelvic floor dysfunction, all of these things that we manage all the time that just aren't as well known in these higher levels of care, you might be denied treatment. And that has to do with access. And I have to very humbly identify that our clinic is a cash-only clinic. Yowza, because I am a liberal woman who believes in healthcare for all, high quality, wonderful healthcare for all. So, that doesn't jive great. The clinic couldn't exist if we tried to take insurance, because insurance has no idea what to do with an internist who specializes in eating disorders. And, we have tried to do as best we can with scholarships, of which we have many, and also with out-of-network reimbursements that patients can often get meaningful reimbursements. But the fact is that we are out of reach for a lot of people. So, in your early comments on helping others, that's where all of the other work that my partners and I do comes in, that tries to acknowledge there's plenty of people who need our help who won't get it directly. But how can we write a book, write a second edition of a book? I know we're going to get to that. Write blogs, do podcasts, do lectures, give away high-quality teaching resources for free to come to other countries, especially ones that don't typically have resources. So one of the pillars in founding the clinic was to uplift the quality of medical care for people with eating disorders around the world. And the notion of access to care, and I didn't even mention the other vitally important ones. Anyone who lacks points of privilege will have a harder time accessing care. If you're a person of color, if you're not a cisgender heterosexual person, if you are other-abled in any way, there are just so many places in which the system says, we can't serve you. And I hope that changes. We're certainly working towards what we can on our side.
Well, there's always hope. And I think even if people have not had the access to care that they deserve, and they have so many comorbidities and labels slapped on them, the fact that they have a medical professional who believes in them and sees their light and sees that it's possible. I mean, peer support is so important, and having providers that will go the extra mile. So many people that have found recovery who were very sick had providers that went the extra mile, dietitian, therapists, taking people out to eat in restaurants and things like that. So sadly, Katie's story and Emily's story didn't end up being a recovery story. And, I say now, and things have improved somewhat since then, but I always say, there's dozens of things I would do different and a million just the same. The love was always there, but the medical community basically wrote her off. And she had a wonderful PCP, she had a wonderful therapist, but sometimes the disease takes such a hold on people that their organs break down, and there was always hope. And I think it's so important doing what you're doing, because you're doing it the way that you have to do it, right? If it's cash, and not everybody can do that, but people are going to learn from your model, and hopefully insurance companies will understand that it's far cheaper to help somebody early on get the levels of care that they need, and find some level of recovery than it is to keep going to the emergency room and places where they just put a Band-Aid on a hemorrhage. And none of this is a choice. So I'm so grateful for you being here. And I wasn't going to talk about anything personal because I didn't know if I could handle it. But you have a way of making me feel safe and comfortable too, Dr. Gaudiani. So thank you. So thank you for that.
Yeah, and I'm so happy you mentioned the coaches that are out there for people transitioning back into life, because there's families out there that are wonderful, But when they've been dealing with somebody for 20 years, sometimes, from age 11 to now, the people that are in their 30s, or, they're tired, they're older, they're tired, and they've got other children, they've got their lives, they're working, and it's hard for them to give up, everything. So it's so wonderful to have these, the coaches out there to help, and what we're doing, the little bit we're doing with peer support, just to have people out there that understand, that have been through the journey, and try to meet people, where they are and the recovery journey. So I think we've,
This one right here.
yeah. Yeah. So what they used to call severe enduring eating disorders is now, I guess, called long-standing eating disorders. And you've seen a lot of patients throughout your years with long-standing. Have there been patients that their recovery surprised you, that, they came to you, that other people gave up on, and they recovered, and that surprised you, that they were so compromised, but they are still living? And
I think that while the clinic sees patients across a super wide age span, in many ways, our clinic is specifically about people with long-standing eating disorders who survive and thrive.
okay.
I'm not sure it surprises me, in that I always believe that there is this huge opportunity to try the next thing, to keep hope, to find what's been blocking the patient, instead of saying, you have to try harder in your behaviors, to say, what can I do to remove obstacles for you so that your extraordinary lifelong efforts now finally find traction? So yeah, I would say that our clinic is often called by patients who are like, I don't know that there's anything left out there for me. I've been sick a really long time, and I don't know what we've got to do, but I hope that there might be something. I mean, we have so much to do. We have really, and I stay incredibly humble, because no matter what our intentions are, of course, there are folks who I see the effort. I too have made efforts. I don't feel well enough, of course. And we try every single day to do better. But the fact is that the majority of folks who come to our clinic have been sick a long time, have been told there's sort of nothing else to do, and they want to find that key. That's why they call, even if they're ambivalent about recovery. And so what feels so exciting is that all the time we see people improving. All the time. An athlete who came to me, at the time she was a former athlete, who came to me following an acute stay. She had been, I want to be really cautious about patient details. She had a pacemaker in because she'd had a history of cardiac arrest. She had very, very complex comorbid medical issues. And at the time she came to the clinic, she qualified to go to a higher level of care. And she said, I will never go back. So you're going to fix me here, or I won't survive, but I will never go back to a higher level of care because I was too traumatized by it. And we always encourage and support patients in being like, well, might you consider it again? What about this other place? We're not trying to keep patients out of the right level of care. But when they say that, we sort of push up our sleeves. And as long as we feel like we've got a shot, if we truly don't feel like we've got a shot, we say, you must absolutely, without question, go to this higher level of care and come back to us afterwards. But where there's a shot, we say, okay. And it's so vital to start with the question, what do you want for yourself? So often I tell my patients, and my partners do at initial intake, you are the captain of the ship. I'm the wind in your sails. Where are we going? Giving them back that autonomy opens up a new chapter of hope and engagement that is the opposite of what's feared about that approach, which is that it's simply going to enable the eating disorder. To the contrary, when these brilliant, accomplished, wonderful, delightful humans are actually told, I'm here to respect you. What do you want? There's an ownership about it after a stage of disbelief a lot of the time and mistrust, because boy, that medical trauma is real, real, real. And so, this patient was like, well, I would like to get back to my sport. I haven't played it in years, obviously. I've been really, really sick. But that would be, if we're talking about wish lists, that would be what I'd want. And instead of being like, well, I don't know if you've noticed, but you have terrible anorexia nervosa and you'll never be able to exercise again, which is sort of what she'd been told by a lot of people. The whole team was like, okay, well, what would that take for you? She was like, well, it would take eating more. And it would take allowing my weight to rise. But I don't want it to go too fast or too high. And I said, I don't care what your weight is. This is a patient who came to me in her 50s. Okay, let's do it. And with that thought in mind, that she could actually move towards something she truly wanted, she said, I also want this pacemaker out because it ruins the neckline of my dresses. It's sticking out there and I don't like it. So over time, with her extraordinary efforts and with medical attention towards PTSD and depression that hadn't been offered before, she got stronger again. And she was like, oh, I'm lifting heavier weights than I've lifted in a long time. I can see why the food is important. And I'm pleased to say that a few years later, she is a nationally ranked athlete. So, that's the kind of thing we're talking about. It's the patient who has never been diagnosed with mast cell activation syndrome, about which there's plenty on our website, who gets treated and they no longer hurt every time they eat, and they get better. It's the patient who thinks they don't have any more rounds in them, and we keep saying, of course there are. Of course there are. What do you need next? What do you need next? The patient who says, I really don't want to go back to a higher level of care, but I'm not able to eat all of my food during the day because I'm so nauseated all the time and because it's overwhelming to see the full plate. Is there any world in which I could have a feeding tube, even though it was hard to ask? And we say, yeah. So we place a little feeding tube and we get everything set up, and she uses feeding tubes overnight. And her nutrition starts to improve and her nausea starts to improve. And she says, this has been really helpful, hard as it is, but I think I need to convert to a PEG tube because I think this is going to be helpful over a long period of time. And I'd like to have access to it so that it's not no food or I'm getting fed in a treatment program. And we said, okay, yes, let's do that. If that's what you feel you need for your body, okay. We talk about risks and benefits, but these are the patients who go on to thrive because that kind of intervention allows them to stay in school. It allows them to stay in their relationships with their dog, their cat, their children, their older parents, their partner. These are the ways that we continue to say, you are so much more than the sum total of the ways you suffer. How can I help you remain in those settings medically and listen to what you say you need for yourself, even if I don't have a perfect measurement or I can't know that every single night you're going to use that tube perfectly. The truth is that by listening to the patients, they have a shot like no other to get better. And that's what we see. This clinic is dedicated to going all out, flat out, as long as it takes for people to get better.
It's so interesting that you say that because just months before Emily passed is the last, well, I wouldn't say last ditch effort, but just kind of as a last resort because we were so isolated and alone, and so was she. But, I got her to go to a gastroenterologist, and she was in the hospital to have a J tube, and then they wouldn't do it. I often wonder the difference that would have made because it would have taken the stress off of having to put the food in your mouth until your brain gets back and, you're not hurting when you eat and all those things. So, I'm just amazed at what you're doing. And I think the reason we're all doing what we're doing here is for people to learn for what we wish would have happened differently, what we would have done different, what we wish we knew then. But thank you for being so open and honest about these things.
I wish that the timeline had worked out that she could have seen me in my outpatient clinic. I know that I only got to care for her at acute, and I wish I could have seen both your girls, who were magic. Ellen, you used the word magic. Your girls were magic.
Well, you're magic. You are magic too.
Yeah, and I think that the shifting of how we're looking at all of this and the complexity of eating disorders that you are so beautifully explaining to everyone, because I think along with the myths is that, we all have heard just they need to eat, but they're easy to get over it. But the more I hear you speak and talk and listen to you, it is the depth of the complexity that people need to really realize. And I just want you to expand a little bit on that. You've named some, different things that could possibly happen, and basically what do parents, individuals, and loved ones need to know? How can they be better informed to understand the direction that you're going in and saying, we need to look at this whole individual. There are complexities that we may be missing.
Yeah, I want to be really gentle as I start to answer this question, because the truth is there's probably no subset of humans more informed and better advocates than parents and loved ones. And I want to acknowledge and honor the astonishing patience, determination, love, resources that they pour into their children. I also think the most important thing to say to parents and loved ones is continue to care for yourself. It's so easy to lose yourself in your child's or your partner's, your sister's need. But the truth is, that's complex for a number of reasons, one of which that the carer has to keep their own tank full, of course, to care for someone else. And the other is that there's such a deep vein of shame that runs through those with eating disorders, that if they see their loved ones sacrificing themselves on the pyre of the longevity of the disease, it adds to the shame. And even if they might say, I want you, I need you, nonetheless, they still fundamentally wish to see their loved ones living a life and caring for themselves. So I think that's just so important to say. And I would add that no matter how brilliant an advocate the parent is, there are obstacles that cannot be surmounted, and you do what you can with what you have. It's just so important to say. Because, I would hate a parent listening to this to be like, oh my gosh, you're just telling me that if I advocated better, my kid would get better. And that can feel like agony. Parents are doing all that they can. That said, continuing to be loud in the service of asking your loved one to be treated as a complex, beloved human is very reasonable and important. I think another interesting breakthrough in recent years that I've certainly experienced is insisting upon treating co-primary psychiatric diagnoses and not saying, first we have to get the eating disorder taken care of. So I'm talking about PTSD. I'm not a psychiatrist, but I've had to learn certain skills, and I'm very grateful when I can partner with psychiatrists on a treatment team around the country, but oftentimes there's not one. There's so much we can do for PTSD. We can use prazosin at bedtime if the blood pressure tolerates it. We can use clonidine patches to smooth the reactivity of the mood during the day. We can refer to ketamine, specifically psychotherapy-supported ketamine. There's a new procedure called stellate ganglion block that provides a reset of the sympathetic nervous system under expert hands. I don't perform it, I refer for it. And it can radically decrease the physical symptoms of PTSD. For ADHD, which I'm convinced now is a co-diagnosis, especially of brilliant, intense young women who learn from an early age that if they make all the focused rules, they can achieve despite their ADHD, and that restriction cools down their brain so that it's less chaotic. If we were to diagnose those young achievers who become overwhelmed at the prospect of needing to do everything right and said, you know what, you might actually have hyperactive ADHD where you just can't hold still in your body and your mind, and we treat them with stimulants, yes, while they are still restricting, they get better. I've had patients whom I've treated for years, whom I realized this in the last few years, and would put them on stimulants, and one said, it feels like I put glasses on for the first time. The world just got focused. Another one of my patients said, I've always been the one who in treatment, they accuse of walking to burn calories, and they put the body bug on me. But when you started me on stimulants, Dr. G, I was able to sit and rest. I was able to focus on meal plan. So, I mean, you know, that we need to treat, because historically, and I did this wrong too, everyone's like, oh, you can't use stimulants in restrictive eating disorders because their appetite will decrease. Well, when was anorexia an appetite problem? But if we treat the comorbid stuff, it gets better. So that's the kind of thing I'm talking about. Like, where are the walls we can blow out so that the room is open?
Oh my gosh.
I love it.
Yeah.
I love it. I love it. Oh my God. Keep having these conversations because you really are blasting open the gates and saying, hey, can we look at this differently? We can do this differently. We need to open up our minds and listen. Oh my God.
Well, you've blown up the algorithms that are out there that are used so often and too often.
I love that.
You've just blown those to pieces. So
Yeah.
thank you. So I have a question, and this is in the current environment we're in now, and eating disorders have always been underfunded, always, you know. And with our current political climate, does this scare you now even more?
Yeah, in so many ways.
Yeah.
Hard to begin to enumerate the ways. But that doesn't mean we're going to give up. That means that it's the parents, the advocates, the podcasters, the clinicians who are all going to have to band together and hold arms and respect each other and realize that if this last election taught us anything, we can't fall apart along micro-theological lines. You know, sort of, we agree pretty much until here, but if you don't agree with me at the very last bit, we're dead to each other. No. We have to all put our arms around each other and come in and be like, I bet every single person in this room has something valuable to provide. And we might disagree about certain features of it, but how can we all learn from each other and do the best work and show up from our patients? I don't think that we can expect some of the larger structural supports that science and research have come to rely on, at least for a while here. So grassroots, baby, we all have an opportunity to be empowered and show up for each other and to assemble as a community of folks who are all looking to help. The less fractured we are, the more horsepower we get to bring to the field because we're not spinning off in our different directions.
Oh my gosh.
That's so well said.
I've
And
said that. So we're stronger together, you know. And
We're more alike than we are different. I so believe that. I mean, we all have the same. We need to nourish our bodies. We need to feel loved. We need purpose. We need, you know, and yeah, it's important to listen to people on all sides of the aisle. And then sometimes it changes your mind about this, that, or the other thing, right? And you've got to just be open and respectful. That's so important too.
We always put out statistics, and those statistics that we tell people, and we're speaking at a church next week, and it's every 52 minutes, somebody loses their life, but I say that's a number. Behind that number is a person that's lost, family forever changed, and we need to get more stories out there, not just people that have been lost, but people that are in the system now and struggling and frustrated. And that's what, that's what we're trying to do here. That's what I advocate all the time, for people to come forward and tell your story, because those are the things that people remember. They don't remember the statistics, and you can throw all those out, how much money it's costing. These are real lives that are affected, and that don't have to be. So, yeah, I've learned so much over the last few years. But I've learned so much today, just in this last hour talking to you. So,
I've learned so much from people who disagree with me on important points too. I want to emphasize that.
Yeah,
Ellen, you have
a tremendous time of learning for me, and I'm deeply grateful for the voices who needed me to understand things differently, and I'm here to listen.
You're a wonderful listener.
And I can think, or I know the three of us sitting here, as well as you have already said, have learned so much through this journey. And it always reminds us that we have to continue learning and growing and understanding and looking at things through a new lens and a different lens. Before we go, I just want to touch base about your book, Sick Enough, the medical complications, talking about blowing off the doors and saying, wake up, people. We need to look at this. That book was it was groundbreaking on so many levels. And then the fact that your book, as well as currently how you want to educate around the world, that people, and that need is so real and so important. The second edition will be coming out soon. Will you just share a few reflections on the impact of your book?
So nice. I hope that Sick Enough Edition 2 will be out end of 2025, early 2026. I am in the process right now. And I'll tell you, just vulnerably speaking, as a recovering perfectionist, it is excruciating to tear apart a completed project. For so long after I sent the book into the world in 2018, it's been a benefit to people, and I've been so proud of the impact that it's had around the world, and people writing in and saying, this mattered, this helped me turn around, this helped my parents understand me better, this helped my clinicians treat me better. I feel so proud of that. Mm-hmm. To receive the Word files and to start tearing things up and moving them around is like, so it's been for sure an exercise in overcoming overwhelm. That said, I feel so excited each time a new chapter is done, because when I read it, there's moments where I'm like, ooh, this is still really good. And then I have moments where I'm like, that's all I had to say about that. So it feels super excited that by the time each chapter is done, I'm like, yes, this is more representative. This is going to help people more specifically. This is going to make people feel more seen. This is going to shift how clinicians provide care. So I'm really excited about it. And boy, I'm in the middle of the swamp right now, and there is no light at the end of the swamp quite yet.
Well, I can't wait for it to come out. I have to tell you that I pick up Sick Enough very frequently and just read different chapters. I mean, I read it from cover to cover when it first came out, but I just it's a book that's on our coffee table, and I pick it up and just read different chapters at different times. So.
And it's educated everybody, but there's no book that you wouldn't change something on, because you're not the same person anymore. Your experience has changed. The different patients that you've treated in different scenarios. It says, and how medically things change too. So you'll probably be doing it again in another 10 years, right? I won't tell you that now. It'll be awesome.
Is there anything you three would like to see in the new edition?
Oh.
I love the personal stories.
Because those are what resonate.
Yeah.
But we will certainly think about that and get, yeah.
I'm thinking that all you've learned over these past 7 years, working with, taking a deeper dive in this new population, all that you have learned and experienced, sharing pieces of that out will be so incredibly important, because it's like okay, this is what we are learning, and this is where we're headed. And that in itself is really exciting.
I think you just might have another book just of personal stories, because I think sometimes when people are in the throes of things, that's just hope. That's just hope going forward. So, I don't know how you do what you do, but God bless you for it. And we are out of time just about. So thank you so much from the bottom of our hearts. We are so grateful, and you are changing the world in such a wonderful way. We extend our sincere gratitude to you and to our listeners. Thank you so much for joining us today and getting to know the dedicated, incredibly knowledgeable, and most kind and compassionate Dr. Gaudiani. We would also like to thank Rockbox Recording and Production and Scott Fitzgerald, who is our remarkable sound engineer, for his exceptional production of our podcast, and so much more. And of course, I'd like to thank my soulmate husband and my dear friend Alan Bennett for making this so wonderful. And I don't think we've ever stuck to a script less than this time, but it's been great. So
I knew that's where it was going.
It was so much fun. Okay.
Don't mind.
Tell your family and your friends about Once Shattered, Picking Up the Pieces. Please rate, review, share, and subscribe on the podcast platform you're listening to us on. And check out our YouTube channel. Learn more about Linda and Jack Mazer, the founders of the Emily Connection and the authors of Emily, the Story of a Girl and Her Family Hijacked by Anorexia, available on Amazon.
And please learn more about the wonderful, colorful Ellen Bennett and her nonprofit organization, KMB for Answers. These discussions that we have are so incredibly important, as they emphasize the importance of mental health for every one of us. Every one of us knows somebody who is affected by mental health. So remember, if you ever need a place to record your podcast, your audiobook, or create a legacy cast for loved ones, as always, Rockbox Recording and Production is the only place to go. So thank you all for listening.